Good evening and welcome to Doctors on Call. It's cough and cold season, so tonight we're going to take your questions about lung problems ranging from pneumonia and influenza to asthma, COPD, and lung cancer. I'm Dr. Alan Johns from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School Duluth. I'm your host tonight. I'm pleased to welcome this evening's panelists. Dr. Mary Owen, a family medicine physician and faculty member at the Medical School Duluth. Dr. Eric Swanson, a pulmonary and critical care specialist with Essentia Health. And Dr. Paul Zimmerman, a pulmonary medicine specialist with Essentia Health. So what would you like to know about lung problems? Call locally at 218-788-2844 or toll free at 1-877-307-8762. Our medical students answering phones tonight are Kristen Heslip of Owatonna, Minnesota, Seth Nelson from Spicer, Minnesota, and Catherine Rogers from Robert, Wisconsin. And now on to tonight's program. Well, gosh, welcome. It's great. There's a lot of coughing, a lot of lung stuff going on these days. So, Dr. Zimmerman, one question that a lot of our listeners probably would like to know is, you hear the words emphysema, you hear the words COPD. Are they the same thing, or is one just a fancier term than the other, or what's the difference?
Right. That's a good question. Chronic obstructive pulmonary disease is really not a diagnosis of a disease. It's more a reference to a group of diseases. And under that umbrella term of COPD are specific diseases like chronic obstructive asthma, chronic bronchitis, and emphysema. And each of those three disorders are defined separately. For example, emphysema is enlargement and destruction of the air spaces of the lung. Chronic obstructive asthma, maybe at one time was simple asthma, but with reversible airflow obstruction. But now it is fixed airflow obstruction, and chronic bronchitis has airflow obstruction. And those three diseases are the predominant diseases that cause chronic, non-reversible obstructive lung disease.
Okay. Well, another question would be to Dr. Swanson. COPD, emphysema, I mean, smoking causes most of it, or a lot of it. Are there other causes that can occur that you can develop emphysema from?
So there are many different reasons for it. Here in the United States, the most common reason is smoking related. Outside of the United States, there are many other exposures, such as cooking over fires and things like that. But emphysema is mainly a disease of smokers. There is a rare cause of not congenital, but a hereditary disease called alpha-1 deficiency. And that's something that it's actually recommended that you get tested for. And it can cause both lung and liver problems. So.
Well, thank you. Well, Dr. Owen, when it comes to asthma, to diagnose asthma, do you need a bunch of fancy tests, or a lot of asthma just diagnosed otherwise or clinically, or?
No, first of all, patients usually come in with some symptoms that are fairly telling. They'll have some more chronic symptoms like a cough, a chronic cough, or some shortness of breath when they exert themselves. And then you can fairly easily test for asthma with something called spirometry, and that's where we test how much air that they can blow out of their lungs at a certain given time. And it can be done in most clinics.
Well, thank you. Well, since we're on the topic of asthma, Dr. Zimmerman, what are common treatments for asthma?
Well, asthma is a condition of airway inflammation, and as a result of that airway inflammation, there's irritation of the airways. People with asthma will oftentimes have cough, shortness of breath, chest tightness, chest heaviness, wheezing, and so we treat that inflammation primarily with inhaled anti-inflammatory medications or inhaled corticosteroids. And that would be really the workhorse of asthma therapy is inhaled steroids. So we treat the disease asthma with inhaled steroids, and we treat the symptoms of asthma, chest tightness, wheezing, shortness of breath, with what's called a bronchodilator, an inhaled medication to help open up the airways to permit more easy breathing.
Well, thank you. Well, Dr. Swanson, so what's the treatment then for emphysema? Is it the same as asthma, or is it different?
So there's multiple different types of inhalers. Typically, we start off with a slightly different regimen of inhalers. First-line therapy is something that is a longer-acting medication to help dilate the airways. Rather than the inflammatory condition, we typically use it more to dilate the airways so that you're not having the same symptoms of shortness of breath.
Thank you. Dr. Owen, a caller would like to know, he or she has a history of smoking and has a cough. So what's this cough from? Maybe I should rephrase this and say, if a person has a chronic cough, what would be common causes of a chronic cough?
Well, certainly if they're a smoker, you could have the cough from irritation of the airways. You could have a cough from badness that we all know of. You know, people who smoke for a long time have higher risk of having, conditions like just acute conditions like pneumonia, infections, worse and long-term would be cancer. Other simple causes might not even be the lungs at all. It could be cough from reflux, heartburn.
Sure.
Can cause that same kind of spasm in the throat that causes a cough.
So yeah, so it's hard to say. You probably should see your physician.
And it depends on how long it's
out.
been going on and if you're having other symptoms. And right.
Okay.
And I might add that oftentimes people who smoke cigarettes who develop cough, they may not have shortness of breath or other chest symptoms. They just have cough, perhaps induced by the airway irritant of cigarette smoke. But cough is oftentimes the first sign of airflow obstruction and impending, smoking-related lung disease. And so you don't have to be short of breath to have lung disease due to smoking. Cough is oftentimes the first sign.
Well, thank you. Well, maybe I'll ask Dr. Swanson this question. A caller from Superior would like to know, what is the treatment now for pulmonary hypertension? Maybe you could explain pulmonary hypertension briefly.
Yeah, so the pulmonary hypertension is a disease of the blood vessels that supply the lung. So you think of systemic hypertension, that's the one most people are familiar with, which is the blood pressure that they measure on your arms or measure on your leg. And when it's elevated blood pressure in your body, they give you certain medications to treat that. There's many different meds for that. But as far as the lungs are concerned, we don't have as many options for treating it. And there are many different causes for it. It can be caused because of a lung disorder. It can be caused completely independent of a lung disorder. But most of the therapies are quite advanced therapies and done by specialists. Oxygen is often the first-line therapy that we give to all people with pulmonary hypertension.
Thank you. I have a question here for a caller from International Falls. So, Dr. Owen, a woman who smokes and she has smaller lung capacity, is she more likely to get COPD, or maybe are women more likely to get COPD than men, would be the question.
I have not heard that, although I will defer to my colleagues here to tell me, is there any difference? I have not heard of any difference.
No, I'm not aware either of any predisposition based on your sex alone.
Nope.
Thank you. Dr. Zimmerman, this is our first caller who asks a question about BOOP. See, I told you they would call
Yes,
ask
did.
about BOOP. Anyway, she would like to know more about it, and how do you get it?
Well, BOOP is an older term for bronchiolitis obliterans organizing pneumonia. That diagnosis or that phrase is no longer used for that diagnosis, and it's now called cryptogenic organizing pneumonitis. And that condition presents with cough, shortness of breath, fever, abnormal chest X-ray, much like an infectious pneumonia would, but it is a non-infectious pneumonia. And the cause is unknown, and that's cryptogenic is a medical word to explain or to use when we don't know the cause. There are often many hypotheses as to the cause of cryptogenic organizing pneumonitis, but for example, chronic aspiration would be one of those, but sometimes it's associated with other connective tissue diseases, but by definition we don't know what the cause is.
Thank you. Dr. Swanson, a caller from Superior would like to know, and this certainly fits into our program tonight, about sleep apnea. What is it and how do you treat it?
So sleep apnea is a very common condition, especially with our population becoming more obese over time. Most often what's causing it is crowding of the upper airway, whether it's the excess weight over the airway or the tongue kind of pushing back and closing off the airway. Typically it's diagnosed by doing a sleep study. And then afterwards, if you do have this, sleep apnea, it's called obstructive sleep apnea. So when you have these obstructive events, you will not breathe. And if you have enough of them, they put you on different types of therapy. The most common is CPAP therapy. It's a form of mask that they can put on your nose or put around your entire mouth and give you some positive airway pressure to open up and kind of stent open that airway so that you breathe throughout the night.
Maybe I'll ask a follow-up question then. Well, what are the symptoms of sleep apnea? I mean, how do people feel? Do they feel bad?
So there are many people who don't have a ton of symptoms. They don't come in complaining of it, but their spouses say, you snore at night, you wake me up because you have these small arousals, and they don't necessarily know it. But if you do have symptoms, the most common would be morning headaches or kind of a fogginess in the morning. Some people will notice that they're falling asleep behind the wheel or falling asleep when they're doing things at work that they should be able to focus on and falling asleep at inappropriate times trying to catch up.
Thank you. Dr. Owen, a caller from Duluth would like to know, what are the side effects of frequent prednisone use?
Well, prednisone is a pretty strong medication. You can get your body too used to it, and then going off of it, that's a lot more long-term, though. Side effects, it can affect your bones. What are the other main ones? It causes weight gain. It is an immunosuppressant, so you can be more subjected or compromised and get infections more easily. Other ones?
Diabetes. Or
the weight gain.
Very good. Well, thank you. Dr. Zimmerman, a caller from Duluth, would like to know, are you more susceptible to lung rupture if you had a lower lobe already taken out?
Well, a lung rupture might be another way to say what's called a pneumothorax or collapsed lung. And there's many causes for that. But for example, if you have chest trauma, that can cause your lung to collapse. If you have a penetrating chest wound, that can cause the lung to collapse. But if you were to have surgery for whatever reason and be missing a lobe of your lung, that doesn't necessarily increase your risk of collapsed lung. And in fact, if you've had surgery on that side, it's very likely that the remaining lung on that side cannot collapse because it will be adherent to the chest wall.
Just from the surgery, you mean?
Just from the surgery.
Oh,
it's scar tissue.
Great. Well, thank you. Dr. Swanson, a caller would like to know about screening for lung cancer. Before, there were no real screening tests for lung cancer, but that's changed, I believe?
Yeah, in the last few years, they've come out with new recommendations for lung cancer screening. The guidelines for that say that if you have greater than 30-pack year history of smoking, which means you smoked 1 pack a day for 30 years or 2 packs a day for 15, etc., and you are between the ages of 55 and 80, then you would be, the recommendation would be that you get screened for lung cancer with a low-dose CT scan. And that's something that a lot of times is driven by the primary care doctors, but also can be done by us as specialists.
Annually.
Annually, yep, every year. And if they find something on it, sometimes you end up getting scans more often, having procedures done for it, et cetera. But the idea is that you find these cancers at an earlier stage so you can treat them before they become advanced and cause as many problems.
Dr. Owen, a caller would like to know, and this is a question that does come up certainly, difference between influenza and the stomach flu. I mean, people, basically, I had the flu. Well, what's the flu?
Well, when we think of influenza and what we get vaccinated against is actually a very strong or a serious infection that can lead to death even. It can be fatal. And it's usually, it's oftentimes an upper respiratory infection, but it can go into the lungs as well. Stomach flu is more of a virus usually, and it's usually more manageable and less severe. Usually you have some upset stomach and maybe some loose bowels, but it doesn't usually affect your lungs and isn't quite as systemic as influenza.
Okay, all right, thank you. Oh, here's a question for Dr. Zimmerman specifically. Whoa, there we go. No, this is a good question actually. A person who has chronic COPD and is on prednisone and inhalers, what else can they do to manage this? How do you know if you need to go on oxygen? How do you know if you need to go to the hospital even?
Well, in the treatment of chronic obstructive pulmonary disease, emphysema, we have inhaled medications, and there's different types of inhaled medications. There's short-acting, long-acting medications. Prednisone, as a rule, we really try to avoid as maintenance medication in chronic obstructive pulmonary disease because of concerns of side effects, osteoporosis, for example, increased appetite, weight gain, and the whole host of side effects with prednisone. If steroids are thought to be a benefit in COPD, that would be somebody that is having maybe frequent exacerbations or flare-ups of their airway disease requiring hospitalization or emergency room visits. And inhaled steroids might reduce the need for that. So we have inhaled medications, we have prednisone or inhaled steroids, and then oxygen is of benefit in people who specifically have a documented low resting blood oxygen level, that by wearing oxygen and normalizing blood oxygen levels, not so much shortness of breath, just normalizing blood oxygen levels, you can delay or prevent the development of heart failure because of low blood oxygen levels and prolong life. So that's the indication for oxygen is a measurement of your oxygen level and document that it is low at rest.
Thank you very much. Dr. Swanson, a caller from Virginia, and another caller too, would like to know about idiopathic pulmonary fibrosis. Oh, 3 people have called about that. Wow, it's a very common topic, and a lot of questions about that. That's different than emphysema, right?
Yeah, so it's kind of on the opposite spectrum from emphysema. So rather than destruction of the lungs by making them in hyperexpansion like you get with emphysema, this is actually thickening of the little septum, the space between your lung sacs. And so when that becomes thickened, you also can develop the shortness of breath, the cough, many of the other symptoms that you get with lung disease. But you get very stiff lungs. They don't relax. They don't accept the oxygen or the air that you're trying to breathe in as well.
Is there a treatment for that?
So there are 2 medications that are now approved for that. The medications do not cure the disease, but they help slow the progression of lung decline. And those, again, are relatively new within the last 2 to 3 years. Those have come out. But they are prescribed rather universally, I'd say. I think most pulmonologists are comfortable prescribing them.
Thank you.
Do they help a lot with symptoms?
Oftentimes it's not much with symptom management. It's more the progression of further symptoms. If you can slow the lung function decline, they won't get symptomatic as early.
Thank you. Dr. Owen, a caller would like to know about yellow mucus. what is the cause of it? And I guess the rest of the question will probably be, well, I've been coughing up some yellow mucus. Does this mean I need antibiotics?
Not necessarily. You can get yellow mucus with a viral infection like you can bacterial. It's a combination of symptoms that make us move toward bacterial versus viral. And yellow sputum is not necessarily the indicator for a bacterial infection.
Thank you. Question for Dr. Zimmerman. Well, not specifically, but I'll ask you anyway. So how do you determine if a lung cancer has metastasized if it doesn't show that it's there it doesn't show metastasis on a CT scan?
Right. So if you do have a diagnosis of lung cancer, and the CAT scan of the chest, which is oftentimes universally done in the evaluation of lung cancer, and there does not appear to be anything else in the chest to suggest spread of the lung cancer, then there's an opportunity that maybe that cancer can be removed entirely, but then to look to see if there has been spread. Lung cancer typically goes to the brain, the bone, the adrenal glands, and the liver. And so there's two tests that we do. One would be an MRI of the brain to make sure that there's no evident disease in the brain, and another test called a PET scan, which looks at metabolic activity. And if there's increased metabolic activity elsewhere in the body, that might be suggestive of metastatic disease that would require further definition.
Did they do PET scans here in Duluth?
Yes, yes. PET scans are done in Duluth at both medical centers.
Thank you. Dr. Swanson, a caller from Duluth would like to know, would an increased hemoglobin be indicative of sleep apnea?
So it can be if someone is having sleep apnea to the point where they are not breathing so often throughout the night that their body is trying to compensate. They can end up having a higher hemoglobin because of those low oxygen saturations throughout the night. But that's not typically how it's diagnosed. That might be something you find concurrently, but often not the main symptom.
Thank you. Dr. Owen, a caller from Duluth would like to know about allergies to molds. Could that cause respiratory problems?
It can cause it can cause a cough, probably from bronchospasm and irritation of the linings of the lungs.
Thank you. Okay, we just have a couple of minutes left here. I'm kind of going through my cards here. Dr. Zimmerman, Zolar, what is that used for, and what is it?
Zolar is a medication that is used in the treatment of severe asthma, and it's an antibody or a protein that is directed towards one of the mediators of asthma that can eliminate a protein in your body called IgE, and that IgE antibody is oftentimes involved with allergic asthma. So if you can eliminate that antibody or block that, then you can improve symptom control, perhaps reduce need for prednisone in people with severe allergic asthma.
Thank you. Dr. Swanson, a caller from Cloquet would like to know about bronchiectasis. Now, we really haven't talked about that. Bronchiectasis, is that like bronchitis, or what's the difference?
So people who have chronic bronchitis may develop a condition called bronchiectasis, or they may have it after just a bad infection when they were a kid, or many other reasons for it. But what that is when the airways themselves are actually dilated open and inflamed, and they are thicker than normal. So a lot of times it's very similar symptoms to a bronchitis, but more on a daily basis where you're having frequent sputum production and chronic cough.
Thank you. Dr. Owen, a caller would like to know from ESCO, how do you prevent thrush if you're using inhaled corticosteroids a lot?
Rinsing your mouth, I believe, is the most common way to avoid it.
After you use the inhaler?
Right.
Yeah. Okay.
Right. Do you guys
And
want-
proper inhaler technique. It's
Okay.
very important to use a spacing device, a slow deep breath, and rinsing your mouth out after use.
Thank you very much. And we're getting near the end of our time here. A caller from Cloquet, Dr. Zimmerman, would like to know the benefits of pulmonary rehab. And do you send people to pulmonary rehab? What can they do?
Right, that was an omission of mine as well in answering the question about treatment of chronic obstructive pulmonary disease. Other than medications, then there is pulmonary rehab. And pulmonary rehab is basically teaching people with lung disease how to breathe and how to breathe better. And pulmonary rehab is very effective in improving quality of life in people with severe, moderate to severe chronic obstructive pulmonary
Thank you very
disease.
much. Well, we're out of time. We have some more questions. They're all very good questions tonight. I'd like to thank our panelists, Dr. Mary Owen, Dr. Eric Swanson, and Dr. Paul Zimmerman, and our medical student volunteers, Kristen Heslop, Seth Nelson, and Catherine Rogers. Please join Dr. Ray Christensen next week for a program on ENT problems, when his panelists will be Dr. Todd Freeman, Dr. Jonathan Glickstein, and Dr. Addie LeCarey. Thank you for watching, and good night.